I would like to talk about a very important subject today, which is how to improve follicular synchrony during IVF stimulation. The outlines will be definition of asynchronous follicular development, what is the physiology of follicular asynchrony, how to prevent follicular asynchrony, whether using the long protocol with or without pills. But the greater problem will be with the antagonist, where you have to use some tricks to decrease asynchrony, such as increasing the starting dose or pretreatment with pills, estradiol, progestin, or antagonists. And in the end, we will talk about lines of management of follicular asynchrony if you discover them early in the follicular phase or late at the time of the trigger. What is asynchronous follicular development? Sitinkaya and Montag defined asynchronous cycles as follicles of all sizes being present, whereas asynchronous cycles were those clearly separated into a small and a large cohorts. So this is asynchronous, where you have different sizes, but if you have distinctly larger and smaller follicles, this is asynchronous follicles. Wang et al. Considered follicular development to be asynchronous when one or two follicles had an average diameter of 4 or more millimeters, exceeding that of the other follicles, and the number of the other follicles was more than 4 or more. So Wang was more precise in the definition. If you have one or two follicles exceeding by 4 millimeters the smaller cohort of follicles, especially if the number of the smaller follicles is significant, that's to say 4 or more, and the difference is 4 millimeters or more, which is more or less equivalent to 2 days or more of stimulation. So when the difference between the stage of development of the leading follicles, the larger follicles and the smaller cohort is more than 2 days, this is asynchrony. Murray et al. Defined asynchrony as one follicle is significantly larger than the remaining cohort on menstrual day 6, where he could define the way to know asynchrony early in the follicular phase, or when 2 lead follicles reach maturity 2 days prior to the cohort reaching maturity. That's to say 2 days is equivalent to 3-4 millimeters difference, as we said before. So what is the physiology? What is the cause of antral follicular asynchrony? In the first days of follicular phase in the menstrual cycle, small antral follicles are differentially sensitive to FSH and have dissimilar sizes, which range from 2 to 8 millimeters in diameter. In the natural cycle, this possibly contributes to the establishment of the dominant follicle. There is evidence that larger follicles are more responsive to FSH than are smaller follicles. The mechanism of antral follicle size heterogeneity remains unclear. Possible explanation is the exposure of small antral follicles to gradient FSH levels during the late luteal phase. Paralleling the corpus luteum device, FSH levels increase progressively to preserve antral follicle from atresia and ensure their subsequent growth. So to explain, in the luteal phase, towards the end of the luteal phase of a previous cycle, the corpus luteum starts to demise, and so FSH starts to rise. The endogenous FSH that start to rise may stimulate some of the antral follicles that are more sensitive to FSH, and they may start to grow in the late luteal phase before you start your stimulation. And that's why these follicles will progress more and more when you start stimulation and asynchrony develops. So some small antral follicles are more sensitive to FSH, therefore they can respond to lower amounts of FSH than others, and so they start their development too early during the late luteal phase. The premature gradual exposure of follicles to FSH may accelerate the development of more sensitive follicles and accentuate size discrepancies observed during the first days of the subsequent cycle. This feature is exacerbated in older women and patients presenting ovarian function defects and short menstrual cycles. In ovarian stimulation, most small antral follicles are required to grow coordinately in response to exogenous FSH to accomplish simultaneously functional and morphologic maturation. طبعا احنا بنبقى عايزين ان كل الفوليكلز تكبر مع بعض عشان يوصلوا ماتوريشن مع بعض، وبالتالي نحصل على اكبر عدد ممكن من الفوليكلز. marked follicular size discrepancies at the end of ovarian stimulation may be disadvantageous because a substantial fraction of SH-sensitive follicles will fail to undergo satisfactory maturation. This reduces the number of viable oocytes and embryos, thereby altering adequate embryo selection, which is a determining factor for achieving a live birth. Therefore, to optimize ovarian stimulation, it is important that the physiologic heterogeneity of small antral follicle sizes should be primarily overcome. And this is the importance of overcoming and preventing follicular asynchrony. How can we prevent follicular asynchrony? We can use either the long protocol or the antagonist protocol. With the long protocol, synchronization is much more easy because the long protocol in itself inhibits FSH in the luteal phase, endogenous FSH, and that's to say you will not have exposure of the antral follicles to endogenous FSH, and synchronization will be much more easy. Whether you use oral contraceptive pills or you don't use oral contraceptive pills with the agonist protocol, synchrony will be achieved by merely using the agonist protocol. In the antagonist protocol, the things are different and asynchronity is much more common. So we have to use other methods to prevent asynchrony, such as increasing the starting dose, using pretreatment with pills, with estradiol, with progestins, and or antagonists. The long protocol, the long agonist protocol. The long agonist protocol entails pituitary suppression by agonists. The suppression of FSH levels before the start of stimulation facilitates synchronization of antral follicles and usually leads to the recruitment of a more homogeneous cohort of follicles with a lower sensitivity to exogenous gonadotropins. Gonadotropin suppression, which maintains the ovary in a quiescent state by controlling gonadotropin-dependent follicular growth, leads to a greater homogeneity of the cohorts that will subsequently be recruited at the time of stimulation. So suppression of the endogenous FSH will homogenize the antral follicle cohort, and in the start of stimulation, you will have most of the follicles in the same size, and synchronity will be much more easier. As we know, in the long agonist protocol, we start usually in the 21st day of the cycle with the agonists until suppression occurs and menstruation begins. Then you halve the dose and continue the agonist, and then you start your FSH stimulation. In this period of agonist in the previous cycle, the suppression of FSH due to suppression of the pituitary will result in synchronization of the follicles, and no follicles will start to grow before the others, and that's why you will have a more or less homogeneous cohort at the start of stimulation, and you will have much less asynchrony. Pretreatment with oral contraceptive pills in the long protocol prevents the initial flare-up that accompanies the start of agonist and may further improve follicular synchrony. Then we come to the antagonist protocol. First, oral contraceptive pills. Historically, with the introduction of the antagonist, it had the advantages of reducing treatment duration, reduced gonadotropin consumption, a lower risk of ovarian hyperstimulation, together with the absence of perimenopausal symptoms and cyst formation. However, the antagonist protocol was shown to result in a lower yield of oocytes and a trend towards a lower pregnancy rate compared with the long protocol. It was assumed that the difference in efficiency between the antagonist and the long protocol could be due to differences in the characteristics of the small antral follicle cohort before the start of gonadotropin stimulation. The use of oral contraceptive pills with ovarian stimulation was first meant to postpone the menstrual period and program oocyte retrieval. ده الاستعمال الأول إن إحنا نعمل programming. لكن subsequently it was shown that oral contraceptive pills increase the synchronization of the small antral follicles by means of extensive suppression of endogenous gonadotropins during oral contraceptive pill intake. The same as happens with the long protocol. So in the antagonist protocol, we start the pills on the first day of the menses, and you give for variable periods, maybe 10 days or more, And then when you start the pills, it is important, and it is very important, to have an exactly 5-day washout period before you start your stimulation. And this period is very important. During this time, bleeding will occur. Whether bleeding occurs or not, on the 6th day after the washout period, you start your FSH and continue your protocol as usual. It was hoped that oral contraceptive pill intake before ovarian stimulation may synchronize follicular development, and as a result, it was hoped that the number of oocytes retrieved will improve and the outcome will improve. Pretreatment with pills, however, was associated with a longer duration of stimulation and a higher gonadotropin consumption. It is conflicting that some authors have associated oral contraceptive pill pretreatment in antagonist protocols with diminished outcome of IVF. A possible explanation was the long-term profound gonadotropin suppression induced by oral contraceptive pills. However, a small RCT showed no effect on clinical pregnancy rate when a short oral contraceptive pill treatment, 10 days, no more, was applied. It is to be emphasized that a poorer outcome with pills was noticed when a shorter washout interval, less than 5 days, between the oral contraceptive pills discontinuation and the start of FSH treatment. So another important point is to keep an eye and to be strictly adherent to the 5-day washout period. However, a potential drawback of long washout intervals, because some authors tried to increase the washout interval to 6 or 7 days, but this has resulted in progressive release of endogenous FSH that precedes the start of gonadotropin administration and may affect the required coordination of antral follicle sizes. So if you increase the washout period, you will lose the benefit of synchronization. In a recent meta-analysis in 2017, Lombolk has shown that in the general population, the ongoing pregnancy rate were lower when a flexible antagonist protocol was used with pills compared to the agonist protocol. So when they used the pills with a flexible antagonist protocol, the outcome was less. However, ongoing pregnancy rate was not different if a fixed antagonist protocol was used with or without the pills. Lombolk also has shown that in PCOS patients, there was no difference in the ongoing pregnancy rate between the agonist and the antagonist, whether a fixed or a flexible protocol was used. Pretreatment with oral contraceptive pills in poor responders may ameliorate ovarian response. The coordinating effect of strong gonadotropin suppression induced by pills may be unfavorably counterbalanced by the unwanted reduction in mean antral follicle sizes, which may interfere with ovarian responsiveness of these follicles to ovarian stimulation. So in poor responders, pills, especially if they are extreme poor responders, pills may deteriorate the condition, not improve it. So oral contraceptive pills with antagonist is a very controversial matter. So in normal responders, to conclude, pretreatment with oral contraceptive pills is not recommended in antagonist protocol, and these are the latest recommendations of the ESHRI. However, this matter is not fully studied, is not completely studied, and still the matter of using the pills with the antagonist is a matter of conflicting results and debate. So if oral contraceptive pills are used, the following must be done to prevent a reduction in outcome. First, you should use it for a short period, not more than 10 days. And you strictly adhere to a 5-day washout period. And you should use a fixed antagonist protocol, preferably day 5 start of antagonist. And you add LH activity when indicated, as in hyporesponders and old age patients. This is in normal responders. However, in PCOS patients, oral contraceptive pretreatment and antagonist protocol does not compromise the outcome. And in poor responders, oral contraceptive pretreatment is better avoided as it may decrease the ovarian response to stimulation. The second item is estradiol pretreatment. Administration of estradiol in physiologic doses during luteal phase has been shown to attenuate FSH levels and effectively synchronize small antral follicle sizes before the start of gonadotropin stimulation. So in the same way, estradiol will suppress endogenous FSH the same way as oral contraceptive pills. However, estradiol suppression is milder, and so its synchronizing effect is less effective. Estradiol valerate 4 milligrams daily starting relatively early from day 20 of the preceding cycle, the treatment is stopped on the first menstrual day, or for programming purpose, E2 can be stopped on any day from day 1 to day 4 of the menstruation. So for programming purposes, we have 4 days of flexibility. Either you stop it on the first, second, third, or fourth menstrual day. And gonadotropin stimulation is started the day after, without washout periods, back to back. So in estradiol pretreatment, you give estradiol valerate, you start on the 20th day of the previous cycle, and once this will not prevent menstruation. Once you get menstruation, you have the option to start stimulation after stopping estradiol, and you start your stimulation the day after exactly with back-to-back manner, and you don't have to leave to give a washout period in this condition because estradiol valerate will end its effect on the pituitary within 24 hours. A potential advantage of estradiol is the milder FSH suppression, which probably results in lesser reduction in overall antral follicle sizes. This is particularly useful in poor responders. Many investigators have shown better oocyte yield, an increased number of mature oocytes, and a lower cycle cancellation rate. However, the duration of stimulation and total gonadotropin dose were higher compared to no pretreatment. However, compared to oral contraceptive pills, estradiol pretreatment is associated with a shorter pretreatment and stimulation duration. يبقى احنا بنزود الستيميليشن ديوريشن والنمبر اوف امبولز اوف اف اس اتش مع الاستراديول بس ده اكتر مع البيلز. It can be used when oral contraceptive pills are contraindicated. The estradiol can be used when you have contraindications of the pills, and it does not affect the fertility potential during the cycle preceding ovarian stimulation. If the patient gets pregnant, there is no harm. However, E2 pretreatment is unable to postpone the menstrual period, which limits its programming abilities. A recent meta-analysis studied steroid pretreatment in IVF. Estrogen pretreatment was not different from no pretreatment in antagonist protocol, nor it was different from oral contraceptive pretreatment in antagonist protocol as regards live birth rate, clinical pregnancy rate, ongoing pregnancy rate, and ovarian hyperstimulation rates. The effect on the number of mature oocytes is conflicting. In some studies, the number was equal. There was no increase in the number of mature oocytes, while in other studies, the number of mature oocytes was higher with estradiol pretreatment. This is the famous Cochrane review about the use of pills and steroids before antagonist and agonist protocol. The second method of pretreatment is the antagonist itself. GnRH antagonist administration in the luteal phase suppresses LH and FSH and effectively reduces the size of synchronized antral follicles during subsequent follicular phase. The original protocol consisted of a single dose of 3 milligram GnRH antagonist administration on the menstrual day 25 of the cycle preceding stimulation. يعني كانوا بيدوا حقنة واحدة من الستروتايد 3 ملغ اللي هو لونج اكتنج اللي ما عادش موجود دلوقتي على day 25 of the cycle, and they start the stimulation on menstrual day 2 because menses comes in time. This is how you use this protocol. You give one single dose of 3 milligram cetrotide on the 25th day of stimulation. You expect the menses in time, and you start on day 2 your REC-FSH and continue the protocol as usual. Lower daily antagonist doses, 0.25 milligram, can be given instead, but for 4 days, not single day. Both transdermal estradiol patches and GnRH antagonists can be combined. You can combine estradiol together with the antagonist, and this was known in the past as the crash protocol. It was specifically used in poor responders. However, there are conflicting data about the oocyte yield and the pregnancy rate, which with this protocol in poor responders, and due to its high cost, it is not recommended. Few studies investigated the use of progestins. Then we come now to the progestin pretreatment. Few studies investigate the use of progestins for pretreatment instead of oral contraceptive pills. We can use noresistrone, hydroxyprogesterone acetate, or ethinydiol acetate. They were used in different studies. Progestin is started on menstrual day 15 for 10 to 15 days, and a washout period of 5 days recommended exactly as in the pills. And this is how the protocol goes. You start on menstrual day 15, your progestin, and then you have a washout period of 5 days, exactly as the pills, and you will have menstruation during that period, and then you start your FSH after the end of the 5 days washout. Of course, progestin can be started anytime. You can start progestin on the first menstrual day for 10 days or so, and then you stop, have a 5-day washout, and then you start your stimulation. Or you can start in the luteal phase, menstrual day 15 or 16, as the way as we described. Progestins have almost the same results as oral contraceptive pill concerning the number of oocytes, duration of stimulation, and dose of gonadotropin. However, it was claimed that progestins do not result in a lower live birth rate, while there are beliefs that oral contraceptive pills may, in certain circumstances, result in a lower live birth rate if used as a pretreatment in antagonist protocol. The available evidence indicates no beneficial effect on live birth rate, ongoing pregnancy rates using progestins as a pretreatment in GnRH agonist or antagonist. However, there is low quality evidence of an increased clinical pregnancy rate with progestin pretreatment in the agonist protocol. So, to conclude the management of follicular asynchrony, if you diagnose follicular asynchrony early in the follicular phase, you can increase the FSH dose. Say you will diagnose it on day 5 or 6 of stimulation, or you can add LH activity if you suspect hypo response or if the patient is above 35 years of age. Late follicular asynchrony, if you are faced with late follicular asynchrony and you are waiting to decide when to trigger, you can trigger according to the larger cohorts. If the smaller cohort is small and you are afraid of hormonal imbalance and rise in progesterone, or you can use double stimulation. You retrieve the larger follicles and you continue you stimulate again in the luteal phase and have the smaller follicles in the second wave of stimulation. Or you can do an extended stimulation. You trigger, retrieve the oocytes, continue stimulation, the smaller cohort will continue to grow, and then you can make another retrieval. Of course, this is complicated by increase in the price due to double retrieval and double ICSI. The other strategy, if you discover asynchrony in the late follicular phase, is to wait for the smaller cohort if they are significantly larger in number. If you have 2 follicles that are large and the remaining follicles you have significant number of follicles, 8, 10 smaller follicles, you can wait for the smaller follicles, but you expect to increase freezing in this cycle because you might have a deleterious effect on the endometrium if you prolong the cycle and allow the bigger cycles to grow and grow. Thank you very much.